All right. Thank you, everyone, for coming. Welcome to another Mackinac Center event. Today, we're talking about the true costs of drug pricing policy. We're going to cover a variety of issues in the healthcare drug policy sector. This is something that affects everybody and will affect all of us much more and more over the years. It's become a very significant part of state and the federal budget. So we're going to talk about what's going on in that area and what we can do to improve it. So first, you'll notice, just as an order of operations here, each of our panelists will speak for 7 minutes. I'll do some questions, and then we'll take questions from the audience. So we have cards on the table in front of you. Please write down your questions, and then we'll have one of our staffers pick that up. And then our last 15 or 20 minutes, we'll go over that. We keep these really tight to 1 hour. And so you'll be out of here on time. And then I'm sure our panelists will be happy to hang out afterwards if you have any other questions. So today we are examining the impact of federal policies, including the 340B drug pricing program, recent changes under the Inflation Reduction Act, on patients, providers, and then also the broader healthcare system as a whole. So this conversation is going to highlight ongoing research, looking at things like what do price controls mean in terms of what has happened to prices, but also what happens to research and the availability of drugs. This is particularly matters to critical medications, rebates, and then incentives out in the marketplace. But it's not just federal policies. Increasingly at the state level, states have gotten in on price controls and subsidies, not always considering the trade-offs of these policies. So if you're concerned about how policy changes affect drug availability and healthcare affordability, this is a good conversation for you. Our panelists today are Naomi Lopez, Tom Wilbur, and Dr. William Smith. Naomi brings over 30 years of experience. She's a nationally recognized healthcare policy expert. She's the founder and principal of Nexus Policy Consulting and an adjunct scholar here at the Mackinac Center. Naomi is the co-founder of the AI in Healthcare Working Group and is regularly featured in the national media. She has penned hundreds of scholarly articles, studies, and commentaries. Tom Wilbur serves as the Senior Director of Public Affairs at the Pharmaceutical Research and Manufacturers of America. He previously served as a senior aide on Capitol Hill for 8 years, most recently as Communications Director and Chief Strategist for U.S. Representative Fred Upton. Dr. William Smith is a visiting fellow in life sciences at the Massachusetts-based Pioneer Institute. Dr. Smith has 25 years of experience in government and corporate roles. His career includes senior staff positions for the Republican House leadership on Capitol Hill, the White House Office of National Drug Control Policy, and the Massachusetts Governor's Office, where he served under Governors Weld and Cellucci. So please welcome our panelists today. And first up, we will have Naomi Lopez.
Good afternoon, and thank you to the Mackinac Center for bringing us together to talk about one of the most critical issues in healthcare today, pharmaceutical pricing policy. I'm honored to help set the stage for what I think is going to be a very lively and constructive conversation. Let's begin with this one simple truth, and that is we're living in the most extraordinary era of medical innovation in human history. New cancer treatments, cures for genetic diseases, the AI-designed therapies are transforming what's possible for patients, not in some far-off distant future, but that's happening today. And crucially, these breakthroughs exist because we've protected the freedom to innovate. The US develops more than half of all new medicines globally, and our leadership in this area is not a coincidence. It's the result of a market-based system that rewards risk, tolerates failure, and when the science works, it delivers life-changing cures to patients. But that system right now is under increasing pressure here in the US. In the name of affordability, we're seeing a wave of proposals that might sound appealing on the surface, price caps, cost affordability boards, one-size-fits-all purchasing rules. But these proposals carry very serious risk. And if we're not careful, we may end up solving the wrong problems in the wrong ways with the wrong results for patients, that being limited access to the most innovative treatments. So let me be clear, affordability does matter, but so does access, so does future progress, so is less time spent in the hospital, so is a longer life at a higher quality. The real challenge isn't just the list price of a drug, it's the true cost of those policies that might unintentionally choke off innovation or limit access to new treatments down the line. Let's take the 340B program. It was designed with the right goal. It was designed to help safety net providers stretch scarce dollars to serve more low-income patients. So the way the 340B program works is that pharmaceutical companies will sell drugs at a much lower price to 340B institutions that serve lower income individuals and certain types of hospitals and community providers. What you see here is what I call the spider map. It shows where Michigan's 340B providers are selling these low-cost drugs, these drugs that were offered at a discount in order to provide more services in the communities. Why in the world are Michigan's drugs being sold to Hawaii? Why are they being sold to some of the most affluent zip codes in the country? They're being sold to PBMs, for example, the pharmacy middlemen who are marking up the prices and not providing the benefits to your communities. Let's also look at state-level prescription drug affordability boards, another proposal here in Michigan today. These boards aim to review drug costs and impose payment caps. But without a full view of the drug supply chain, including PBMs, insurers, hospitals that mark up drugs, and rebates, they risk distorting the very market that they're aiming to fix. And worse, they scare off investment in high-risk areas like rare diseases and cancer. And I'll also point out the current bill in the Michigan legislature right now has a fiscal note on this proposal, and they're estimating it could be $4 to $5 million per year. There's also the rise of value frameworks like quality adjusted life years. On paper, these aim to rationalize spending, but in practice, they devalue the value of an individual who has a disability, who's older, who maybe doesn't have full mobility. So in practice, they end up rationing care to the most vulnerable patients, assigning a lower value to the lives of these individuals. And what we need to understand too is that at the federal level, most favored nation pricing is being proposed. But what that's going to do is that's going to bring that framework that is used all over the world to ration drugs right back here through the back door. What's missing in these debates too often is honesty about where the money is actually going. There's just not a lot of transparency between manufacturers and patients. There's a complex web of pharmacy benefit managers, wholesalers, insurers, and rebate structures that you and I don't see. Patients often pay out of pocket based on list prices, while everyone else in the chain negotiates deep discounts behind the scenes. So what should we do? We don't need to choose between affordability and innovation. It's possible to have both. We can require PBM rebate transparency and ban spread pricing. We can promote real-time cost tools that show patients and prescribers the actual cost at the point of care. We can make sure that copay assistance programs count towards patients' out-of-pocket maximums. We can support and encourage outcome-based payment models that link costs to the results of those treatments and not arbitrary caps. And we can also help restore the integrity of the doctor-patient relationship in this process. This is the path forward. It's transparency, it's competition, it's patient empowerment, and most importantly, it's innovation. Because in the end, this isn't just about numbers on a balance sheet. It's about the patient in the rural town that's waiting for a cure, the parent hoping that a clinical trial becomes a treatment for their child, the senior who deserves both affordability and dignity in their healthcare. The question isn't whether we reform drug pricing, it's how we do it without destroying the very system that has delivered more medical miracles than any other nation on earth. Let's protect the future of medicines by making smart policy choices today. Thank you.
Thank you, Naomi. Let me start by thanking Jared and the Mackinac Institute for the invite. I have warm place in my heart for Michigan because my doctoral dissertation was published by the University of Michigan Press. And anybody who's gone for a doctorate knows how hard it is to get it published. So I'm deeply in debt to the state of Michigan and to the University of Michigan. Let me start out by making a very controversial statement. And the controversial statement is Americans have access to the cheapest prescription drugs in the world. And you'll say, that's impossible. Hey, we know that drugs are more expensive in the US than in Europe. And how could this be? How could the US have cheaper drugs? Well, the reason is 93% of prescriptions in the US are generics. Generics are medicines, branded medicines that have lost their patent and can be copied by generic companies, and they can sell them very cheaply. And American generics are cheaper than generics in Europe. Europe has very expensive generics. And I personally would like to maintain a very robust generics industry because the generics industry provides cheap drugs, great technology, but very inexpensive. And the price control initiatives that have been proposed, both on the federal and the state level, are going to hurt the generics drug industry. And let me explain why. My friends here from Bristol Myers, one of my favorite drugs is Eliquis, which is a anticoagulant. It's a blood thinner, and it's a great drug. And prior to price controls, it had a list price of about $521. After price controls, it will have a price of $231. That's the federally imposed price. So what happens when Eliquis loses its patent is that a bunch of generic companies will submit an application to the Food and Drug Administration, and they will ask, can we be the first generic copy of Eliquis? And the generics company that completes the application quickest will get the ability to sell Eliquis for 6 months with no competition. And this is the most profitable period for a generics company. So at $521, the generics company will probably sell that medicine for $450, $475. They'll have to give some discount to get insurers to cover it. But they didn't do the R&D for the drug, and they're going to collect almost $500 a month for the drug that they didn't invent. So this is an extremely profitable period, this 180-day period, when you get exclusive right to sell the first generic. And that maintains a very robust drug industry, generic drug industry for the US. Without that 180-day period, a lot of these companies wouldn't survive because they ultimately end up selling the medicines for nothing, for $5. But when price controls take effect, the Eliquis won't be sold by that first generics company for $450 or $475. It'll be sold for probably less than $200 because the government has pushed the price so low. That makes the attractiveness of the generic drug industry much less. We're going to have a less robust generics drug industry because of these price controls. And let me talk a little bit about another sort of unintended consequences of price controls. The politicians in DC crowed recently that they had finally beaten the pharmaceutical companies and they'd imposed price controls on Medicare drugs. And so Pioneer did a bunch of research recently, and it's just being published this month. And let's take Eliquis. At $521, the list price, pre-price controls, Eliquis probably gave Bristol Myers Squibb the ability to pay PBMs and health plans a $200 rebate. And what that rebate bought for Bristol Myers Squibb is low out-of-pocket costs for Eliquis and low paperwork requirements for physicians. In other words, the rebate makes it easier for patients to access the drug. That's what the rebate dollars do. That's the way the system works. I'm not blessing it. I'm just saying this is the way the system works. So when the government pushes the price down from $521 to $231, the rebate goes away. Now, how do health plans and the PBMs make up for the lost rebate cash? Well, at Pioneer, we wanted to find out. And what we discovered is that they pushed up out-of-pocket costs for patients above to where they were before. So the price controls have made the drugs that are price controlled and the prices were pushed down have made it less affordable for those particular drugs for patients to afford. Out-of-pocket costs for the first 10 drugs that were price controlled have risen 32%. And Eliquis in particular, it rose from an average of $78 out of pocket to $106 out of pocket. That's kind of the perverse incentives that happens when you impose price controls. So with that, I'll take questions, and I like talking about 340B. I've been talking about it for a long time and happy to take questions on that.
Great. Can everybody hear me okay? Well, first and foremost, thanks to the Mackinac Center for having us here today. I'm really excited to be here. My name is not Peter Fotos, as it's listed in your pamphlet today. My name is Tom Wilbur. I'm the Senior Director of Public Affairs at Pharma. I oversee our communications and campaigns in all 50 states, including here in Michigan. And I'm also responsible for our Voters for Cures program, which is our grassroots initiative. So what Pharma does and is a trade association based in Washington, D.C. We represent the top 31 innovative biopharmaceutical companies across the world. And each day, the scientists and researchers at our member companies wake up every day with a very simple goal. That's to treat and cure the diseases that afflict all Americans. We've made tremendous progress over the years towards that goal. We have cancer survival rates that have improved greatly over the last number of years. HIV is now a manageable condition, and we've cured hepatitis C. That's because, in part, the United States is the world leader in biopharmaceutical innovation because the policies that have been put in place encourage competition, and they encourage drugs to hit the market the fastest that they can hit the market in the safest way possible. Unfortunately, we have a lot of inefficiencies in our broader healthcare system. Right now, 50% of the money that goes towards a medicine goes to other entities that have no role in developing or manufacturing a medicine. So whether we're talking about the 340B hospital markup program, whether we're talking about middlemen like PBM who run rampant with abuses in the system, something needs to change. And so I'm excited to be here today so we can have a good discussion about what some of those solutions are so that we can really lower out-of-pocket costs for Michiganders.
All right, thank you. So you mentioned a couple of times that there are laws in the system that allow or push for a lot of the expense that we're seeing. So you mentioned 340B, you mentioned pharmacy benefit managers. What laws are in place that encourage that? And how can we just explain how that actually works?
Well, I can explain how the 340B program works.
You might be the only one who can.
Basically,
I mean, really.
What hospitals can do under the 340B program is buy drugs at a very low price and then resell them to insurers, commercial insurers first and foremost, but also Medicare at a much higher price, and then pocket the spread. It's called arbitraging the discounts, and that's the way hospitals secure revenue through 340B. They buy low and they sell high. But what that means is that commercial insurers and employers and Medicare and a lot of other people are overpaying for their prescription drugs for the benefit of hospitals. Now, hospitals sometimes say, well, guess what? There's no appropriation for this program. It doesn't cost the taxpayer anything. That's really not true because Medicare is overpaying for the drugs because the hospitals have bought them at a very cheap price, and Medicare gets charged at a very high price. So it does cost the taxpayers money, and there are also studies to show that, not surprisingly, 340B hospitals tend to prescribe more expensive drugs. The more expensive the drug, the more spread you can pocket. And so employers who get their employees treated at a 340B facility are going to end up paying more, and their premiums are going to be higher. That's just the reality.
The most shocking thing about the 340B program is that when the law was enacted, the congressional intent was that the savings would go to provide more healthcare services. The problem is that there's no check on that. There's no transparency. What we do know is that a lot of patients who should be qualifying for these discounted drugs are being sent to collections because they're not being given a discount because they can't pay their hospital bills. The organization called Patients Rising, they're at patientsrising.org. They detail state by state where the 340B drugs are being sold, how many pharmacy benefit managers those drugs are being sold to, where geographically they're being sold, like for example, Hawaii and Palm Beach. So what's needed now is two things. One is for the federal government, for Congress to pass a law that says that there either has to be transparency or they have to knock it off when it comes to pocketing the savings. The second thing is to avoid bills like the one that's being considered here in Michigan that would allow them to double down on this program. And so we need patient engagement on both the federal and the state level. And if you want to dive deeper into exactly what's happening in Michigan with the 340B program, patientsrising.org, like I said, has detailed this for all 50 states, and that's where you can get the information about where Michigan's 340B drugs are being sold.
Completely agree. And just to put a finer point on that, the 340B program was created in 1992 by an act of Congress. I think at that point in time, it was meant to serve approximately 100 hospitals. It's now a $66 billion program serving nearly 3,000 hospitals, including, I think, nearly 90. Jarrett, fact check me on that. Right here in Michigan. I think the number is 86. And so it's really being used as a profit center for PBMs, chain pharmacies. And so more than anything, 340B, we need some transparency in 340B, and we need some oversight in 340B.
And on the pharmacy benefit managers, can you talk about, I think two of you mentioned kind of how that works. What is the inefficiency in the system? What law allows that? What is happening? I follow Mark Cuban on Twitter. He hammers on that a lot. I'm not sure I totally understand it, but maybe you can enlighten me.
Yeah, so pharmacy benefit managers accept rebates and fees from pharmaceutical companies, and in return, they can prefer that particular company's drug. You would think that would be illegal. Do you think that'd be a bribe? But it's not. So it's kind of, drug makers are required to pay kind of protection money to the pharmacy benefit managers to prevent them from restricting access to their drug. You know, the pharmacy benefit manager approaches Bristol Myers Squibb and says, "That's a nice little drug you got there. A shame if something happened to it." And the Bristol Myers Squibb pays money to make sure that the patients can access it easily and physicians don't have to require a lot of paperwork. You know, you would think this would be illegal, but it's not.
So there's one state reform, and I haven't looked deeply at this, and so I'm not endorsing this as a solution, but this legislative session, Governor Sarah Huckabee Sanders in Arkansas just signed a bill that makes it illegal for the pharmacies and pharmacy benefit managers. They're the same people. So imagine what kind of collusion might be taking place in this kind of a program when they're selling to themselves.
Yeah, PBMs are a little bit confusing. I can recall we started talking about PBMs 5 or 6 years ago, you know, and going up to Capitol Hill, and nobody even knew how to spell PBM. They were just so opaque. Nobody knew what they did or what was going on. And so we really raised the alarm. And as it stands right now, 3 PBMs control 80% of the market. And ultimately, if you have any questions about PBMs, just know that they're the ones who decide what drugs you can get, what hoops you have to jump through to get the drugs, and ultimately what you pay for the drugs. And so I think, as you alluded to, there's been some great action in different states on PBMs, including here in Michigan. I even want to say there was a law signed in 2024 on PBMs, but more needs to be done, and there needs to be some federal laws that are on the books as well.
Yeah, and you know, it seems like a lot of what we're we're talking about is interesting. It crosses a lot of kind of left, right, conservative, liberal alliance. I mean, I think from our perspective is moving more towards a free market system. So what are the government laws in place that are encouraging kind of this monopolization, the higher prices, those types of things? A little bit of a broader question. So we're talking about, there's this conflict between sometimes affordability and then the quality and the improvements in healthcare. So from just like a public policy perspective, especially at the state level, what's the role of lawmakers to try to figure out that balance of affordable drugs while also keeping the investment that we see, allowing the market to kind of work long term?
So there are there's no silver bullet. I mean, this is going to be a very long process, but we are seeing some really great inroads being made. So for example, when we take a look at Mark Cuban, Cost Plus, his organization, they're manufacturing drugs, but they're also creating new networks of pharmacies. Let me give you a personal example. My son was on the generic form of Singular, and it's called Montelukast. The list price for this was $120 a month at that time. From GoodRx, we could obtain it for about $60. Through my employer, it was about $15. But buying it directly from our direct primary care provider, including the 50 cents that he charged for the brown bottle, was about $1. The price that individuals pay for a drug varies dramatically depending on what kind of customer you are and who you're buying it from. So what that means is that we need a lot of transparency, and we need to make sure that it's legal to buy cash, that you can buy a drug for 90 days instead of just 30. The reason is that to fill a prescription, it can cost like say $10 at the pharmacy, but if you're filling it for 90 days, you're not paying the extra 20 for the other 2 months. So there are a lot of steps that can be taken in terms of making it legal to have more types of arrangements. Another possibility is we carry around these supercomputers in our pockets now. And one thing that we can do is allow for the seamless transfer of prescriptions from pharmacy to pharmacy, allowing an API on your phone to shop for the best price. That can make a big difference too. So there are a whole lot of different ways of creating transparency and competition. Amazon getting into the cash market is a big step forward. We are seeing more competition coming online, and one of the great things about generics that William has been talking about is that it is the greatest untold story in healthcare, I think, right now, and untold because we know about a lot of the innovations, but because the generic market has been so robust, even though we're bringing new treatments for certain types of dystrophies, genetic therapies for dystrophies, and sickle cell anemia. I mean, these are multi-million-dollar treatments. We're not seeing a dramatic increase in drug spending overall, and it's because the generic market has been so effective in treating.
Medicines are the only thing in the healthcare space that get cheaper over time because of our generic market and the robustness of that. And that's thanks in large part to our gold standard intellectual property system. But to your point, you have to be able to balance affordability and innovation. And when you look at the generic market, it's been a huge success coming out of the Hatch-Waxman Act, and it's really been incredible to see.
There are no generic knee replacements. The knee replacements don't drop in price to 10% like generic drugs.
LASIK has gone down a lot. I'll give a plug for LASIK because my parents made me pay for it myself in those early days, and I still remember those bills. So we've seen movement on some of these issues at the federal level, at the state level. What are you seeing, for good or bad, that the federal government is doing, especially with the Inflation Reduction Act, and what's happening at the state level that we should all keep an eye on?
Well, I'll defer to Naomi on the state level. But on the federal level, you have this price control regime, which is kicking in. The first year, they price controlled about 10 drugs. Next year, it'll be 15, the year after 15, then 20, 20, 20, for as far as the eye can see. So in the blink of an eye, the 100 leading prescription drugs in the Medicare program are going to be price controlled. The impact on R&D will be significant. It'll be billions and billions of dollars. So we're already seeing clinical trials get canceled and certain types of clinical trials get canceled because of this. But I'll defer to Naomi on the state level. I think she has her pulse on it.
So I'll talk about both the federal and the state level, actually. So at the federal level, there are a lot of negative things happening, like tariffs, perhaps, on the pharmaceutical industry, as well as most favored nation pricing, as I mentioned before, which would basically bring terrible models through the back door into the U.S. So some of the good things that I think we will probably be seeing at the federal level will be a movement more towards a fail-fast approach to drug development. It can cost billions of dollars to develop a treatment and bring it to market today. And part of that cost is all of the failures that happen early on or in the middle or even at the late stage of the drug development process. So by having a fail-fast policy that allows a drug to be tested quickly and then allowing researchers and manufacturers to move on quickly is going to be a very important step in the right direction to bring down these costs. Capacity for drug development in this country is also going to be very important. I think that the current administration is going to be supportive of not only bringing more drug development into the United States, but also supporting that through incentives and the like. And then I think we're also probably going to see some more innovations in the actual clinical trial process. My understanding from a drug developer that has an ALS pill in phase 1 of clinical trials is that it's going to soon be they're going to be allowed to expand that pretty dramatically in the early clinical trial development process so that more patients can get access, and it's less than $500. So the very first treatment that has a potential to actually reverse some of the very detrimental symptoms of this devastating disease. And we now know that there's a pilot program at CMS, the Centers for Medicare and Medicaid, where their innovation department, if you will, is going to be having demonstration projects on gene therapies in the Medicaid program. And the first one is for sickle cell. And so the value of these treatments, I believe, will become very apparent very quickly in the current administration. I think that that is a goal. I think that some of their policies that they're putting forward are very counterproductive, but I'm seeing very positive developments in those particular areas. At the state level, one of the reforms that I work on is called Right to Try for Individualized Treatments. I'm the architect of that particular legislation. It's now law in 10 states, and it will soon be signed in 4 more this session. That allows rare and ultra-rare disease patients whose physicians are recommending an individualized therapy to obtain treatment without first having to go through the federal bureaucracy in order to pursue that. When those treatments begin, when patients actually get access to those individualized treatments without going through the FDA, we will see a very dramatic price difference in the one-off treatments versus the ones that are going through the FDA process. And, obviously, if there's an effective treatment, it can often be translated into other disease areas, particularly in the rare and ultra-rare spaces. For example, if it's neurodegenerative, those can often be applied in other areas. But that is going to help whenever we're talking about the very high dollar types of treatments as well. That's one of I think the most innovative state laws. Another one is Minnesota now has a more transparent 340B law, which is which I think is pretty robust, but they can go further, and I hope that other states will go further. But we're actually now able to see that the value of the drugs that are now being put onto drug affordability board scrutiny being sold under 340B. It's a really tangled web.
All right, we got a ton of questions, so we'll move on to some audience questions. I'm trying to combine a couple of these that are along similar themes. So, first question is, do you support extending patents on different drugs or any other changes to the patent system that we need to make?
So I'm very involved in the drug innovation space, the laws around that, particularly as they relate to the FDA. I'm pretty agnostic about what the time period should be, but I absolutely oppose March-in rights, basically taking a patent for anything that is less than the current patent protection time plus a day.
I don't think you're going to need to extend patents. It will not reduce drug prices. The drug prices are set by what the market will bear, not any other thing. And so extending patents will not decrease the price of drugs. I also think, and Naomi said this earlier, AI is going to help reduce the R&D costs significantly and reduce the time frame in which drugs get to market. And that will essentially extend patents because you'll have more time on the market to sell exclusively.
Yeah, I guess, it's an interesting area because it's, you need to encourage the investment. So you got to give rights to a certain amount of time. I know other countries do it very differently. In your opinion, does the United States have the right mix on this? Somewhere else we can replicate? I've heard there are countries that have essentially no patent system, and so they get no investment into major pharmaceutical changes.
Other countries can do this poorly. The problem for the pharmaceutical industry is that, say, unlike the auto industry, they have very high R&D costs up front and then very low manufacturing costs. Once they discover the molecule, it's easy for them to manufacture it and cheap. I remember when I was at Pfizer, the manufacturing guys bragged that they could make a Lipitor pill for 5 cents. Now, it costs $3 billion to discover Lipitor, but they could make it for 3 cents. But that business model of high R&D costs and low manufacturing costs makes your industry very susceptible to freeloading by countries abroad. Like if England said to the Ford Motor Company, we're going to buy your F-150 truck, but we're only going to pay $10,000 for it. The CEO of Ford Motor Company would say, go pound sand. We can't make a truck for $10,000. We have high manufacturing costs. With a pill, it's different. They've already invested the R&D and they're trying to recoup as much revenue as they can. So if England approaches a drug company and says, you know what, we're only going to pay 50 cents on the dollar, the CEO has a difficult choice to make. It's unfair, the price they're offering, but is he going to walk away from $50 or $100 million in sales in that one particular country because they're offering an unfair price? And that's the dilemma of these international trade problems.
A lot of questions on the 340B program. So one, just should we prohibit, hospitals from using this program? How does it work? Is it just nonprofit hospitals? Do all hospitals have access to it? And then, a question that if you do limit that program, which is a big revenue maker, especially for these rural hospitals, well, what do rural hospitals do? How do they make up that money that they might use for charity or for providing care for people?
Yeah, the 340B program is not a black and white program. There are clinics and hospitals that are doing the right thing with the 340B money. They're giving out a lot of charity care. They're providing care uncompensated, and they're doing the right thing. There are some hospitals that see it as a profit center purely, and they're just taking as much revenue as they can, and who knows where they're spending it. They could be spending it on executive salaries or parking spaces. We don't know what they're spending it on because it's not required to be disclosed. So it's a mixed bag, and that's why I'm reluctant to argue that the program should be cut, because you'll hurt institutions that are doing the right thing. That's why I think the best solution is transparency up front. How much money are you making from this program? Hospitals need to disclose. And what exactly are you spending it on? If we could know those things, we would know a lot about the bad actors and the good actors in the program.
I think transparency is the key. There are hospitals around the country that are doing phenomenal work and really serving patients well, and really upholding the integrity of how this program was originally envisioned. But I also like to talk about the crane index. How many cranes does your hospital have? And a lot of times, the charity care that they're providing are glossy promotional marketing materials. There's just not a lot of transparency on how these hospitals are using the revenue from these drug discounts.
I said it at the top. We need transparency and oversight in the 340B program. I think we're in agreement on that point, because without that, we really just don't have a good understanding of what's happening with this $1 billion program. It's become the second largest drug program in the country, and we really have no idea what's happening with it.
Well, we do have some ideas. I mean, we can map out where the drugs are being sold and who they have the contracts with. And they're not other community facilities. They are PBMs and pharmacies in other states, oftentimes, and often the most affluent zip codes around the country. So we do have some transparency there. We just don't have it on the hospital accountability end.
So what do you say? You're a rural lawmaker here in Michigan, and your local hospital is telling you we need this program. How are you going to vote to limit it, or how are you not going to vote to continue to expand it? You know, what do you say as a lawmaker?
I think you say, show me the money. How much money did you make this program, and what did you spend it on? And then you'll know whether they're doing the right thing by the program. And
I think that's your second movie quote so far, Bill. So only one
Yeah,
more.
sorry.
on the panel. Okay, yeah.
Well, and we know that Minnesota has taken a very important first step in transparency. I think building on that kind of an approach would be what I would tell Michigan lawmakers to do next.
Question on how do you anticipate the tariffs, the potential trade war? How is that going to affect prices in this area? You know, especially with, you know, they name with China, but also with Canada, Mexico, any other countries.
Well, I'll go first because I don't want to get ahead of anything, but I believe my organization is submitting comments today to the White House on the Section 232 proposal. Traditionally, as it relates to tariffs, medicines have been excluded because it could lead to shortages for patients, which is not something that we want to see. So I don't want to get in front of my my organization's submission, but I did want to jump in there and just say that traditionally we've not seen tariffs on medicines, and so we'll continue to work with the White House to make sure that that is the case.
I think tariffs probably will raise drug prices from pharmaceutical companies like GSK that are located in Europe. On the other hand, we do have a serious national security problem in that many of the raw materials for our most important antibiotics and other drugs are made in India and China. And we need to build a system in the US where we can manufacture those things ourselves. That's the reality.
Yeah, I'm very concerned about the impact of tariffs on drug prices. There's no question that a lot, if not all of those increased costs will be passed on to the consumers in some way, or all of it. So I absolutely agree about the national security implications of drug manufacturing. The FDA has announced that they are going to ramp up foreign inspections of drug facilities, which is a really important step in the right direction. My understanding from talking to people who are very familiar with these processes is that they get a lot of lead time. They know when the inspector is going to arrive several days later. There's a lot of, it's not a true surprise inspection. And so
Seems like some of the restaurants, you know, I worked at as a kid.
So that should be helpful. And then also the current administration's statements that around the intent to help support manufacturing here in the U.S. in terms of providing incentives. You know, we know that from other countries, for example, Japan, which has a very I will call it a very modern drug approval, where they do provisional approval in phase 2 of clinical trials for gene therapy, regenerative medicine type treatments. They give provisional approval for 7 years in phase 2 of those trials. That led to a lot of foreign direct investment in Japan in improving their capacity to manufacture these treatments. I would love to see, and we've already seen actually some announcements from some major pharmaceutical companies announcing that they are in fact going to build facilities here in the United States. That's an important step in the right direction, but there's a lot of different type of manufacturing. There's the very, the gene therapy, regenerative medicine type treatments, but then there's also just generic manufacturing. And I think that there are problems with the inspections taking place. There are problems, and so creating a robust supply chain domestically will be very important.
So there's a lot of incentives and subsidies for drug research, R&D. So how do we financially incentivize disease prevention? So how can we work to structure the system with the goal of keeping people off medication by stopping diseases before they start?
So we're seeing a lot of we have been seeing a lot of innovations in the health insurance space. I think that's where these incentives are most appropriately placed. It's in employee type wellness programs. Whenever you take a look at the self-insured market, those are the markets where the large employers, state workers, for example, they have a lot of ability to do innovation in this particular area because they're not subject to the same set of rules that the traditional health plans are subject to. So I think that's where we really want to be looking for those types of innovations and incentives to be placed, see what works. And what was the first part of the question? I was going to answer that too, and I forgot what that was.
Oh, just regarding, we do have a lot of incentives for general drug research, R&D.
Well, we do, but right now there's one really important program for pediatric rare disease that has not been reauthorized by Congress. That's very concerning. It's a voucher program for research into these areas where you don't have a very large patient population, and so the cost of getting something to market may not be recouped without additional incentives. We've seen that go away. We're seeing a lot of concern amongst researchers that are funded by federal grants who have lost grants and the like. So right now, we do have a lot of incentives, but it's not really clear what that's going to look like going forward.
I think the Make America Healthy Again movement has brought a lot of this to the forefront. And listen, we support a holistic approach to health, but when you're sick, you need a medicine. And so I think that's where we come in, but we've always been on the side of prevention, taking care of yourself, and really having a holistic view of health and healthcare.
Well, and I do think some of these drugs are involved with the prevention part of it. I mean, the weight loss drugs that have been coming on, the GLPs, are about preventing these worse diseases, later. So it kind of does go hand in hand. Last question, and then we'll wrap up here. So President Trump did sign an executive order on transparency, pricing transparency. There's been bills in different states. Michigan had one. It got through our Senate, didn't get through our House. But you're talking about transparency in the 340B system. We also have like the hospital pricing transparency bills. Is there an effect that those are having? Is it just like an EO that never went anywhere and didn't mean anything? Any thoughts on?
There's been a lot of EOs recently, Jared. Can you be more specific?
Yeah.
I don't know. No,
not really. How do you feel about these laws regarding hospital pricing transparency?
So hospital pricing, I'll have a couple of things to say about it. One is that while collusion is illegal, coordination is legal. So during the Clinton administration, the Department of Justice came out with a memo that basically said that they cannot collude, but they can coordinate. So you have the same consultants helping them coordinate prices. And so transparency in a lot of cases doesn't actually have an impact if the prices are very similar in a particular geographic area. The second thing is that a lot of these approaches don't actually have any teeth in them. And then part of the issue too is that honestly, people don't care that much about hospital prices unless they're actually paying for that. And, people are busy. Even when offered the tools through some insurers, which have some pretty good transparency tools, people don't use them. And so the idea that, this is a silver bullet, I don't see that happening anytime soon until the consumers are really paying first dollar for hospital stays or for high cost treatments. Now we are seeing some positive movements in terms of people shopping, particularly the self-insured market, where there's a tertiary market for surgery centers, things like rotor cuff surgeries, knee replacements, hip replacements, where a self-insured employer will negotiate. They have great claims data on their population. There's not a lot of churn. The same people are in their risk pool for many years. So they know how many heart stents they're going to need. So they're able to negotiate for a small fraction of the total cost with surgery centers around the country for these types of treatments. That's where hospital transparency is actually making a difference. It's in the self-insured markets where they're getting dramatic discounts, and even in many cases where it's cheap enough that you can take someone with you, you can make a vacation out of it. I once helped an employer have his employee get hernia surgery in Las Vegas, where that's all they did, and they got a Las Vegas vacation out of it for a lot less money. I think it was like maybe $5,000 compared to $30,000. And so that's where that's going to make the biggest difference. Transparency in the 340B program is a little bit different in that we want to see where these drug savings are they going to patients. And we know in many cases that they're not, and that those same patients are being sent to collections when they should have gotten the benefit of this particular program.
Yeah, I read the Trump drug pricing EO, and I think I know which one you're referring to. And it was kind of a grab bag of things. It was a bunch of different things. But the most interesting part in it is he instructed Health and Human Services to look at the overpayment by Medicare for 340B drugs. They're buying Medicare, hospitals are able to buy drugs sometimes at a 75% discount and then bill Medicare at full price, which is costing the taxpayers a lot.
All right, please thank our panel. Thanks for joining us today. We hope you check out more of our work online at mackinac.org. We have a bunch of publications over there you can grab on your way out. And for those in the area, we have a couple of upcoming events. So on May 28th, our next event is 5 years from lockdown. Emergency powers are still a problem. And that will be here, same location, same time. And then later in June, we will do the real cost of red tape, rethinking occupational licensing in Michigan. So we'll be back here. We will provide lunch, and we hope you join us again in the future. Thank you.